Thank you very much for the invite. Sorry, I couldn't have been there in person because of some personal commitments, but it's always an honor to be presenting in a meeting like this. So I'm going to be talking about the multi-modality imaging in the structural heart interventions. We all know that the structural heart interventions, it's constantly evolving. There have been improvements in technology, procedural techniques, and much more critically in the imaging guiding these procedures. And if we look at the spectrum of the structural heart interventions, they range from the commoner, like the TAVI, mitral clip, ASD, VSD closures, so on and so forth. And the imaging, it plays a critical and central role in each one of them, and it guides every stage of the patient care. So if we look at the different stages, so in the pre-procedural imaging, it's very important to have a proper transthoracic echo, a TEE, and a cardiac CT. And once a need is identified for an intervention, then the anatomical suitability, the device size and type, and the vascular access strategy. Beyond that, once the patient is selected for an intervention, then it's usually the combination of the fluoroscopy and the echocardiography, and it's the 3D echocardiography and the recent advancements of them which have revolutionized the structural heart interventions. And if we look at the different interventions, there are different modalities for each one of them. So for a TAVI, majority of us know there's the CT, which is essential for the pre-procedural imaging. When we come to the intra-procedural imaging, it's the fluoroscopy, which is a cornerstone. The TE has very limited role there because majority of these are now done under conscious sedation. If you compare that to the other procedures like the mitral clip and the left atrial appendage occlusion, they are mostly TEE, the 3D TEE guided, and I'll be giving a couple of examples of those. TAVI we are all aware of. CT is a cornerstone for access site, for annular dimensions, and then for the coronary ostia and their height to have an appropriate and proper procedure. But I want to talk about two other procedures. One of them rather simple one. The second one will be a more complex one. Paravalvular leaks, not an uncommon problem. Even in the developed countries, 2 to 10% of AVRs, 7 to 17% of MVR might have significant PVL, and these patients can have serious clinical consequences. The surgeons, understandably, they are not very keen on a redo surgery because the mortality can be as high as up to 37%. So that's why we need to have alternative management plans for these. And the cardiologists are going to be more and more involved in these. I'll present the first case of a 49-year-old gentleman. He had a mechanical aortic valve replacement, which was a Medtronic Hall, for severe aortic regurgitation secondary to a bicuspid aortic valve. He was developing more shortness of breath over the next 2 years, and he had significant paravalvular leak. He was referred to us from Lahore. We did a transesophageal echocardiography on him, and if I can point to the area, so interiorly, we can see that there is a gap next to the implanted valve, and that's where the paravalvular leak was coming from. We thought this patient to be a candidate for percutaneous closure. We brought the patient to the cath lab. So in the first image, if we look at the fluoroscopy, I think everyone will appreciate that we can see the tilting disc of the AVR, but it's very difficult to appreciate where the PVL is and where exactly the leak is coming from. But we can appreciate that much more clearly on a transesophageal echocardiography. And again, under the guidance of the TEE, we can cross this space with either a glider wire or with a normal 035 wire. And the 035 wire actually has a distinct advantage here because it's much more visible on the TEE, and it can guide the procedure there. So once we are in an appropriate space for deployment of the of the device is then put again under the TE guidance. And once we are happy that we are in the proper place and it's going to seal the leak, then we deploy and we can see on the TE that the valvular leak is appropriately closed. So this was a rather simpler use of the TE in a paravalvular leak. I would like to talk a bit more about the mitra clip, which is a truly TE guided and a fluoroscopy assisted. And if I want to push it, I might say that you can do a mitra clip with a minimal of fluoroscopy. Even someone might say that you can do it even without fluoroscopy, which is a step too far. So if you look at the selection criteria for patients to consider the mitral clip, they are based on the Everest 2 trial, moderate to severe mitral regurgitation, pathology ideally in the A2P2 area, but now the operators are pushing it more and more. Coaptation length of more than 2 millimeter with a coaptation depth of less than 11 millimeter and a flail gap of less than 10 millimeter with a width of less than 15 millimeter. So each one of these need a very good echo assessment even before we consider a patient for mitral clip. So once a favorable anatomy is identified, then the patient undergoes a TE and it allows a detailed assessment for the procedure. The preoperative assessment, basically, there are three views on the TE, which involves the 3D TE as well. So the main view is the bicommissural, which is explained to an L view, T view. I will show that in a bit. The second view is a bicable view with an explained to reverse aortic valve short axis, and this is for the optimum septal puncture spot. The third view, which is very important, is a four-chamber view for the height of the puncture. So once the patient comes to the cath lab, we reassess the mitral apparatus. We look at the mitral regurgitation, we look at the left atrium and the left atrial appendage for any thrombus, and we document any presence or absence of pericardial effusion. So as I was mentioning earlier, the main view is the bicommissural view with the cursor across the mitral valve, and in the X-plane view, we'll have an L view, T view, and we put color on that, which shows an eccentric jet of mitral regurgitation. We assess the mitral valve further by sweeping from medial to lateral. So the cursor is taken from the medial to the central and then to the lateral side, and we can assess each and every part of the mitral valve. So once we have done that, then we measure the length of both the leaflets and we look at the fly gap as well and decide on the appropriate mitral clip size. Beyond that, then we come to the interatrial septum. I just want to show the baseline 3D. So this is the 3D, which is a clock face. It is Z-rotated to put the aortic valve in the interior position. Then the commissures should be at the 10 and 2 o'clock. And we put color on that and we can very clearly see the mitral regurgitation, and that will be the area that we will be targeting with our mitral clip. The interatrial septum, I know that the experienced operators, they would do it fluoroscopically, but with these interventions, it's very important to guide these with a TE because the anatomical landmarks cannot be seen on fluoroscopy. And again, it's the position of the septal puncture which is important to be very accurate. And I will just briefly show. So it's a bicable view with the inferior vena cava and the superior vena cava, which is explained to a aortic short axis view, and that's where we do the puncture. In the four-chamber view, we want the puncture height to be at least 35 millimeter, 35 to 40 millimeter, depending on the pathology of the mitral regurgitation. I will just skip these and go directly to when the puncture is done. So we do the puncture under the TE guidance. The needle is brought back from the SVC till it falls in the fossa, and then we double check in the four-chamber view to make sure that our height is appropriate. Once the puncture is done, then it's very important to follow the wire, which is the stiff wire. And we try to avoid the left atrial appendage. The wire goes into the left upper pulmonary vein, and then the mitral clip itself can be delivered over this wire. So the mitral clip, again, is brought under the TE guidance. It is taken across the mitral valve. The position is checked in relation to the commissures of the mitral valve, and then it is deployed. uh, Once we are happy with the position of the mitral wall, and we are happy that the mitral regurgitation is reduced, which is checked again in the 3D. So this was a clock phase that I was showing earlier. Again, the aortic valve is interior. We want to make sure that the commissures are at 10 and 2 o'clock, and the mitral clip is nicely across the gap in the mitral valve. We again check that there is a nice bridge across the mitral valve, that the mitral valve leaflets are taut, and we check that the mitral regurgitation has improved. Once we are happy with the position, then the mitral clip is released again under the TE guidance, and the guide is removed. So this will complete our procedure, but before we take out the TE probe, we want to make sure that there is no significant complication. If there's an arterial septal defect, it should be assessed, and if need be, it should be closed at that time. So I would finish by just putting a few take-home messages. I think that cardiac imaging is a cornerstone of the structural heart interventions. There are different modalities, and it's essential for the operators to be able to perform and analyze the images themselves. Apart from the CT, which is essential for the TAVI, the transesophageal echocardiography plays a central role in each and every one of these procedures. And I think with these procedures becoming more commonplace, there's a need for standardized training. Thank you very much.